For this surgical dissection, we're going to show the sinus tarsi approach for the use of the combo plate for calcaneal fractures. The combo plate is a combination of the anterior process and posterior process plates. This can be used for Sanders type 2 fractures. In those fractures that are more comminuted or with more extensive anterior involvement, typically a Sanders 3 or 4, then it is recommended that the standard calcaneal fracture plate be utilized. Bony landmarks that the surgeon should be familiar with are the inferior fibula, the calcaneocuboid joint. The extensile lateral approach utilizes the interval between the perineals and the Achilles and extends proximally, comes down to the apex, which is where the plantar and dorsal skin meet, and then is brought anterior towards the calcaneocuboid joint. For the sinus tarsi approach, this is technically between the superficial perineal nerve and the sural nerve. However, care must be taken to avoid them, as there may be aberrant branches. I prefer to slightly curve my incision, and this can be brought inferior and posterior to the fibula. The reason I prefer to do this is that this does have the ability to be extended both distally and proximally. Prior to making determination for the exact surgical approach, one needs to review the CT scan and pattern of displacement, as there is a highly variable pattern of fracture involvement with calcaneal fractures. With this incision, we will enter just above the posterior facet of the joint, and I am now in the entrance to the sinus tarsi. It's helpful to take out the sinus tarsi contents to get better visualization of the articular surface. The origin of the extensor digitorum brevis can be identified and reflected inferiorly, and if possible will be repaired at the end of the case. You can see we now have exposure of the posterior facet of the subtalar joint. At this point, the perineal tendons can be mobilized, and we see both the peroneus brevis and longus in this dissection. It is not uncommon to incise the calcaneofibular ligament, which is seen in the proximal portion of the dissection, and at this point we will incise that to gain better exposure. The perineals are mobilized, and this can be done with a key elevator or broad instrument. Now remember, with the fracture, one will typically see lateral wall blowout. It is key not to dissect within the fracture site. Once that lateral wall is mobilized, and you can also bring the elevator posteriorly to fully expose that lateral wall, it can be helpful to use a K-wire to retract the soft tissues so that you don't need to continually retract the perineal tendons. What you can see at this point is this is the posterior facet of the subtalar joint. This is the talus, and the posterior facet of the calcaneus here, which will be displaced and laterally extruded. Here, dissection has been done in a subperiosteal manner, and you can see that we are approaching inferiorly the calcaneal cuboid joint. Similarly, the perineals have been reflected out of the inferior retinaculum, and this gives us nice exposure of the lateral wall. The next maneuver will be to insert a threaded Steinmann or Schantz pin in the inferior calcaneal tuberosity to aid in reduction of the fracture. The Schantz pin has been inserted, and as you can see, I am able to readily manipulate the fracture. These fractures typically have shortening, lateral wall extrusion, as well as varus angulation. So the manipulation of the inferior fragments is one of longitudinal traction, as well as bringing that heel into valgus. In addition, one can tamp the lateral wall back in its proper orientation after the lateral articular surface has been elevated and reduced. Once the fracture has been disimpacted and provisionally reduced, a series of K-wires can be utilized to help reduce the lateral posterior fragment to the medial sustentaculum, or what is called the constant fragment. And if necessary, additional K-wires are used longitudinally to maintain length. For the purposes of this surgical dissection, we will not be placing K-wires. However, that is the order of reduction necessary for this fracture. We've selected a medium combo plate, and we will slide this posteriorly and provide provisional reduction, at which point we will get a confirmatory C-arm shot. Typically, the most important screw is the initial reduction of the posterior facet fragment. This can be achieved either through the plate, as we are showing here, or on occasion, an independent screw can be used at the surgeon's discretion, typically a 4-0 screw or a 3-5 if this is good quality bone. The advantage of the sinus tarsi approach is that this has a lower incidence of wound healing problems, and as mentioned at the start of this video, this incision is made in the internervous interval between the superficial perineal nerve and the sural nerve. We've attached the locking guide. Given the good contour of the plate to the lateral wall of the calcaneus, it is possible to begin with a locking screw. As a surgeon, I like to put my offhand along the medial aspect of the foot so that I can get feedback as to when I have actually perforated the medial aspect of the calcaneus. Now remember, this being a locking screw, it is not necessary to make this a bicortical screw. I am able to read my length directly off of the locking guide. If you are using the screwdriver in the ratchet mode, try to avoid torquing. And you will see that this is a nice, smooth, easy way of screw insertion. So we see at the end of the case, articular congruity has been reestablished as we have smooth gliding motion of the subtalar joint. This is a Harris axial view. We have not, for the purposes of this video, we have not filled all the holes, but you see a good outline of the inferior calcaneus. This is the sustentacular fragment or the constant fragment, and our two locking screws that were placed.